Ultrasonography in the intensive care unit has become a valuable tool for expeditiously, safely, and effectively diagnosing and treating a constellation of conditions commonly encountered in this setting. Over the last decade, ultrasound in trauma patients has become an extension of the physical exam through the application of the FAST. More recently, ultrasound has spread to the ICU. In the critically ill, a quick survey with the ultrasound probe can provide crucial information regarding volume status, grossly evaluate cardiac function, and determine the presence of hemorrhage in the chest or abdomen. Additionally, ultrasound assessment of IVC collapsibility is proving to be a reliable method to monitor intravascular volume status in mechanically ventilated and non-ventilated patients. Ultrasound has been widely accepted and incorporated into critical care practice as a guide for ensuring accuracy in procedures such as thoracentesis and paracentesis, is being used to assist with thoracostomy tube placement, and is arguably a standard of care in central venous catheter insertion. The management and resuscitation of the critically ill or injured patient remains a complex issue in the ICU, despite all of the methods of monitoring currently available. Ultrasound, refined for use in the ICU, provides information using validated techniques that are available at bedside, non-invasively, with minimal risk. The ability to perform and interpret ultrasound and echocardiographic studies lie well within the surgeon's skill set. Realizing that the physiologic questions in the ICU are complex, ultrasound provides meaningful impact for the clinician interpreting the test and answering the medical question at hand. Through even a gross estimation of cardiac function and fluid status, valuable information can be obtained to guide a complex resuscitation and arrive at clinical decisions earlier compared to the application of other hemodynamic monitoring modalities. For these reasons, ultrasonography augments the physical exam and allows for a better evaluation of the critically ill or injured patient. We are happy to present a selection of our ultrasonography application and experience in our ICU. A 61-year-old male was transferred from an outside facility in septic shock for tertiary level of care. The patient's septic origin was from a ruptured hepatic abscess encountered during surgical exploration for colonic obstruction. The patient was maintained in a small rural hospital for 4 days on vasopressor support and mechanical ventilation with worsening renal function prior to transfer. On arrival, the patient was on maximum doses of 2 different vasopressors, had not made urine for over 24 hours, and oxygenating poorly on escalating ventilator settings. Our initial evaluation utilized echocardiography to assess his volume status in order to guide our resuscitation. Initial echocardiographic imaging revealed hyperdynamic cardiac wall motion, collapsible right and left ventricles, and a collapsed inferior vena cava. Volume resuscitation was begun with aggressive crystalloid infusions. 4 hours after initiating resuscitative efforts, echocardiography was used to assess for effect. More inferior vena cava volume was noted, but still varied significantly with respirations. As our efforts continued, the patient's vasopressors were weaned and his urine output had improved. And approximately 8 hours after initial resuscitative efforts, repeat echocardiography revealed a volume-replete IVC with essentially no respiratory variation. At this point, the patient was weaned completely from all vasopressors and making adequate urine per hour. A 70-year-old female was involved in a motor vehicle collision where she suffered rib fractures and a complex L2 fracture. The patient was intubated prior to stabilization of her L-spine and proved difficult to wean from the ventilator. She went on to require escalating ventilator support where her PEEP and FiO2 requirements were too significant to risk transport for CT imaging. Her chest X-ray revealed bilateral haziness and basal atelectasis but did not explain her ventilator support requirements. Ultrasound was used to evaluate her chest, revealing significant pleural effusions bilaterally and compressed pulmonary parenchyma at both costophrenic angles. Thoracentesis was performed under ultrasound guidance bilaterally, resulting in improvements in her oxygenation, ventilator settings, and chest X-ray. A 69-year-old male was struck by a motor vehicle, suffering facial fractures and a spleen laceration requiring splenectomy. 6 days post-operatively, the patient was receiving treatment for an ileus and a urinary tract infection when he exhibited an acute clinical deterioration demonstrating tachycardia, hypotension, and oxygen saturations in the mid-60s on a non-rebreather mask. The patient was transferred to the ICU. Pulmonary embolus was suspected, but given the patient's poor pulmonary performance, he was deemed unsuitable for transport to obtain a CTA chest. Echocardiography was used in our initial assessment to evaluate volume status and cardiac function. Echocardiography revealed a widely dilated right ventricle, essentially twice the size of the left, paradoxical septal wall motion, markedly increased right-sided end-diastolic pressures, and a taut IVC with no respiratory variation, all suggest of echocardiographic findings of pulmonary embolus. Systemic heparinization was begun and supplemental oxygen support continued. After several hours of support and observation, the patient's hypotension and tachycardia improved, his oxygen saturations maintained a satisfactory value, and his respiratory rate slowed. A CTA of the chest was performed, revealing a large 10 by 2.5 centimeter thrombus in the right lower pulmonary artery and another embolus in the main pulmonary artery. Preparations for catheter-based thrombolytics were made in the event the patient worsened or failed to improve in a set observation period. However, the patient's oxygen saturations increased, his supplemental oxygen requirements weaned, and thrombolysis was avoided. New horizons for ultrasound in the ICU include the development and application of temporary transesophageal probe placement for assistance in managing the complex trauma or post-surgical patient. An aggressive approach to the golden hour for trauma continues to be the linchpin between resuscitation efforts and successful outcomes. In this day and age, the trauma patient as well as surgical patient are often older with multi-system issues. The comorbid post-surgical patient can provide a particular resuscitation challenge as this population requires early and accurate decisions regarding their volume status, cardiac function, and resuscitation needs. TEE allows for surgeons to get to resuscitation answers quickly and have immediate access to hemodynamic assessment and treatment effects. TEE has long been the gold standard to assess for patient cardiac function, but its availability in the past has been limited to non-surgical specialists and required expensive, complex equipment to ensure adequate image resolution and capture. With the newly developed miniaturized disposable transesophageal echocardiography probes, hemodynamic monitoring for complex resuscitations can be achieved quickly, continuously, and easily, with the probe being able to be left indwelling for up to 72 hours. The views obtainable include the transgastric view to assess for preload and contractility, the mid-esophageal view to inspect biventricular size and function, and the superior vena cava view to assess for volume status and fluid responsiveness. A 71-year-old female status post open abdominal aortic aneurysm repair was transferred to the ICU for postoperative care. Despite intraoperative reports of aggressive volume replacement, the patient arrived in the ICU hypotensive, tachycardic, with low urine output and on a significant amount of vasopressors for hemodynamic support. A transesophageal echocardiography probe was immediately placed and assessment of her volume status was performed. In the superior vena cava view, the patient was noted to be volume depleted through the identification of a small diameter SVC. Her mid-esophageal view revealed hyperdynamic cardiac wall motion and collapsible ventricles. Aggressive volume replacement was initiated. 3 hours after resuscitation efforts, repeat TEE was performed to assess for effect. The patient's SVC view revealed an increase in its diameter. The patient's mid-esophageal view demonstrated slowing of her cardiac wall motion and less collapsibility. The patient went on to wean from vasopressor support, maintained normal hemodynamics, and extubated a few days later. In conclusion, with the expansion of ultrasound's application in the ICU, the surgical intensivist now has a new, powerful tool in hemodynamic assessment. The safety and utility of bedside ultrasonography performed by intensivists has now been well demonstrated. This technology, as an extension of the physical exam, will become an indispensable monitoring modality in the management of critically ill patients. Equipping critical care physicians with ultrasound and echocardiographic skill sets in order to perform point-of-care examinations will translate to improved outcomes and better patient care. Thank you.